So tonight, our speaker is Dr. Heidi Bloom. Dr. Bloom has been at Seattle Children's since 2003. She is a professor at the University of Washington Department of Neurology and is director for Seattle Children's Headache Program. Dr. Bloom has a board certification in neurology with special qualifications in child neurology. She went to medical school at Harvard Medical School. She has a master's in public health and epidemiology from the University of Washington Medical School. Dr. Bloom did a residency in pediatrics and child neurology at the University of Washington. And Dr. Bloom enjoys working with colleagues to improve the understanding and treatment of pediatric headache disorders for children, families, and healthcare providers so that children can manage these potentially disabling disorders and get back to a normal life. So, perfect person for this presentation. So, without further ado, I will let Dr. Bloom start the presentation.
Thank you very much, Patty, for that very kind invitation. And I've been out I think as many of you know who were my attendings when I was a resident, some of you, I've actually been here since 97, but I've only been on faculty since 2003. So I've now been here a really long time and I'm feeling a little old. But thank you for joining us. Hopefully you have some hors d'oeuvres or drinks so we can listen to this. And thanks for joining us around dinner time. And I think, again, the American Headache Society, this is a slide deck that they've prepared with a lot better graphics and some cool extras and something I would be able to provide to really make sure that we're getting the best info and most recent information out to private practitioners and primary care providers regarding migraine. All right. So these are the disclosures of both the AHS as well as myself. We're doing some studies on some of the newer medications for kids here. That's my main disclosure. Otherwise, the other disclosures are for the folks who've helped to develop this slide set. If you have any questions, you can let me know. But so the things that we're going to go over today are mainly to identify migraine as a significant and disabling neurological condition in kids and adolescents, all the kids that you see in clinic. And you probably wouldn't be here if you didn't already realize this to some extent. To differentiate some just easy things to differentiate between primary and secondary headaches to figure out if it's a migraine or something else. Identify those kids who will need newer imaging or who should be referred to neurology and who should be able to stay in primary care. And then develop a plan for treating migraine, both acutely as well as reducing attack frequency through preventative measures, not just medications, but other things as well. So for migraine in pediatrics, so what is a migraine? These are the things we're going to talk about today. Who gets migraines? What is a migraine? That's actually a more difficult question than you might imagine. What kinds of things we can do to manage migraines is kind of the second half of the talk, talking about education, lifestyle modifications, what to do and how to treat an acute migraine, sort of what I call the migraine killer treatments, and migraine prevention. And then also talking a little bit about migraine and contraception, because I know that comes up a lot. A lot of folks have questions about that, and it's still an area that's a little bit unclear. So first, what is a migraine? It's not, quote, just a headache. It's an inherited disorder characterized by sensory, autonomic, vestibular, cognitive, and GI symptoms. Like GI passage rates are even slower during a migraine. Often there's fuzzy thinking, changes in pupillary dilation, other things, dizziness that are all going on around the same time as the headache. So the first phase of a migraine, and not everybody has all of these phases, but the premonitory symptoms may be yawning, fatigue, being cranky, mood changes, sometimes neck stiffness. Sometimes there's a consideration that those things that people think might actually trigger their migraines might actually be a food craving before the migraine. So trying to figure that out can be interesting at times. Then if some people have an aura, about 20% of people with migraine have aura, but most people don't have more aura with all of their headaches. And the visual aura is really the most common thing that we see in pediatrics. Then the headache comes and the throbbing pain, the nausea, fatigue, lights hurt, sound hurts, super cranky, very irritable, feeling pretty miserable. that lasts for in kids anywhere from 2 to 72 hours. And then the postdrome, I sort of call it the migraine hangover, where you're just tired, you still feel kind of foggy, just not quite right, maybe still a little nauseous, some neck stiffness, sort of a milder headache, which can last up to 2 days for some people, or even longer. So pathophysiology of migraine. So back even when I was in med school or even before, we had thought it was really just a vascular phenomenon. A lot of the treatments focused on trying to cause vasoconstriction. We now know that it's not that simple. Um, well, as you know, there's no pain receptors in the brain. There, we know that the there is pain cycle going from those pain fibers in the dura or surrounding the blood vessels in the dura in through the trigeminal ganglion and involving the trigeminal cervical complex, so that's sort of brainstem, um, cervical nerves and cervical regions, uh, and then feeding back up into the thalamus and cortex. So it's this not straightforward, sort of complex network of fibers. But the truth is that we still don't fully understand like why migraine starts, what is the generator of migraine for most people. And what I tell families is that there's probably hundreds, if not thousands, of different reasons why people get migraine. We know that's true for epilepsy, and we're a lot further ahead in epilepsy in terms of figuring out the genetic causes. But we know for certain forms of migraine that are more severe, like hemiplegic migraine, there's calcium channel genes that can cause migraines. We know that there's mitochondrial dysfunction and changes, genetic changes that can cause migraine. So there's really just probably hundreds of reasons, if not thousands, and the whole genetics of migraine is complex. And as you know, one just because one person in the family has one type of migraine, the next person does not have the same. Their kids don't necessarily have the same. It skips around in families. It's not straightforward. So there's a lot we still need to learn. So that said, who gets migraines? Is it common or not common? It is common. It's a billion people worldwide. It's one of the most disabling syndromes of all through that the WHO global burden of health uh, studies. It's affecting about 10% of kids, up to 25% of women in some studies, 20 to 25%, and fewer men, but still 1 in 16. So it's pretty common and it can be very disabling. So with migraine in pediatrics is particularly interesting because there are these other syndromes that can be associated with migraines, like colic, and for which Amy Gelfand has looked at and sort of followed kids and found that colic was associated with migraines, but not with tension type headaches, interestingly enough. And if you think about what happens with babies with colic, that's maybe kind of the infantile equivalent of a migraine. Paroxysmal, benign paroxysmal torticollis, with a head turn, stuck, hitting your head stuck to the one side when kids are toddlers, early toddlers, is another form that's been associated with migraine. Later on, a little bit further into toddlerhood, sort of 3, 4 year olds can have the benign paroxysmal vertigo where you have dizziness for a few minutes or a few hours. There may be vomiting, they may have photophobia, they may feel pretty miserable. Um, and I have had one patient who sometimes would have attacks that lasted a couple of days. Obviously, those kids are going to get a big workup, make sure there's nothing else causing their ataxia or vomiting. But it is something that we see in these families with migraines. Then cyclic vomiting and abdominal migraine. You guys all know a lot about that. Are managing the kids with these functional abdominal pain and recurrent vomiting without other causes. Oftentimes, I think I've seen most often is a history that the kiddo had recurrent abdominal pain or functional abdominal pain through elementary school. And then as they get into junior high and high school, and it starts to turn over more into migraine headaches. I see that more in girls in my clinic, but I haven't seen that data in research studies yet. And I will say there are a few slides through the slide deck that could my practice is slightly different, and this is one of them. Um, so that for males and younger boys, there are studies that show that younger kids, school age kids, there's actually a higher prevalence of migraine in boys and girls. and that switches around puberty. So aside from the far left side of this graph, I agree with it. Otherwise, there's a predominance of females. Prevalence peaks in those middle years, which is one of the issues that makes it such a disabling problem because it's affecting people in quote the prime of their life between 15 and 50. So I don't know what that says for me at this point, but um, it can be very disabling. It's also common. Migraine is just as common as ADHD, asthma, allergies, or hay fever, ear infections. So, and there are some studies, there's a national study, population based study that actually found an association between migraine and asthma. Well, they aren't sure why still. Migraine does have these inflammatory markers or quote inflammatory soup of all these inflammatory modulators that get released during a migraine. And while I certainly do not claim to know much about asthma, those types of factors are similar to what's being released and what's happening for asthma. So that's something that is still, we don't understand why that is. And certainly nobody's currently treating migraine with asthma medications, but it's an interesting phenomenon that we've seen. Migraines also is another slide. I'm sure you don't have to tell you guys on this talk today that migraine is a disabling disorder. These are looking at percentage of these issues for kids with and without headaches. So school attendance, school related problems, repeating a grade, while are not the majority of kids with migraine or with headaches, are certainly more. These issues are much more prevalent in kids with headaches than without. So migraine diagnosis. When is it a migraine? What's a tension type headache? When do we need to worry about other things? So the reassuring patterns are these acute episodic headaches where you have a headache, it comes on, you're feeling miserable, throwing up in bed, and when you go to bed, you wake up the next morning, everything is fine for several weeks, and then it happens again. There may be a pattern if it's like on Mondays after not sleeping on the weekends, or um, if there's a certain stressor or trigger that's triggering the migraines, you can find patterns that way. But this pattern, with everything being completely normal in between, is a reassuring pattern. The other pattern that is more reassuring is what we call chronic non progressive. So these would be the kids that we're seeing in clinic who I meet for the first time, but they've had this headaches for the last 3 or 4 years. Everything's the same. Nothing's changing. Their exam is still normal, but they have a chronic headache. Patterns we worry about are this chronic progressive headache that just keeps getting worse and worse and worse. It's not getting better. It's always there. So those are the kids that we want to consider neuroimaging in or further evaluation. The acute thunderclap headache. Again, if it's the worst headache of their life, thunderclap headache, can't stand up, they need to go to the ER. However, its acute pattern could also be associated with influenza or could be the first migraine. So if the kiddo doesn't fit some of the other factors we're going to talk about in a few minutes, then this might be a kid that you could watch and see, is the headache going to be better in 2 days and then they're back to their normal selves, or is this something that's just going to keep getting worse? The other pattern that we worry about is a new daily persistent headache where they never had a headache at all and then suddenly have a headache that doesn't go away. So those are also the kids that not always, often don't have a dangerous cause to their headaches, but are kids who are going to need further evaluation. The other is the change in headache pattern. So you used to have headaches once a week or once a month, and they're a certain type, and it was frontal, high frontal, migraines, photophobia, phonophobia. And then they get a new headache that's like behind their ear or in the back of their head that's there every day, just getting worse. Those types of changes in pattern are another concerning. So how do you figure out primary versus secondary? Or the other way to put this is like, when should I worry about something dangerous? Primary headaches, the most common type of primary headache that brings folks to the doctor is a migraine. Tension type headache, may be more common, but it isn't seen as much in doctor's offices, at least not here in the US. The pattern's a little different in Europe for some reason. Other types of rare headaches would be like primary stabbing headaches, cluster headaches, hemicrania continua, other things that be pretty uncommon, but still primary headache disorders. And secondary headaches, again, looking at trauma or injury, cranial, in, intracranial space occupying lesions, tumors, vascular disorders, non-vascular disorders, dental issues, infections, medication overuse, are all things to look at for secondary headaches. So if you're worried about secondary headaches, again, those are kids who are going to need further workup with a neurology specialist, ER, or one example I had was a kid who had just come into different care and had never had dental care and had some big, significant dental caries and headaches on that side. And I said, look, you need to get those, let's try and get those fixed first and see how things go with your headaches. So I don't, hopefully have seen this before. The Snoopy mnemonic. Basically, on your history and exam, you want to screen for red flags, and then if they're fitting some of these Snoopy mnemonics, then refer to specialists or further evaluation. So S stands for systemic symptoms like fever, so weight loss, myalgias, vision changes, vision loss, um, those types of things making me worry about infection or other secondary headaches. Second S in Snoopy is for secondary risk factors, like if they're immunocompromised, if they have a history of cancer, they could be pregnant. That I admit has happened to me once, where they found out that they were pregnant, and that was one of the reasons their headaches were changing. Any neurologic signs. So if the kids has new neurological findings or symptoms, then they need to be seen either urgently or emergently. Typically, they have papilledema. We do have a whole system now about trying to get those kids seen and appropriately and get imaged. So there's a whole network that's separately on accessible through the ER or through our neurology contact lines. Certainly, if there's a new focal deficit, if they're weak on one side, they have altered mental status, seizures, those are no-brainers. You're going to bring them in. When I have, so I don't see those kids in clinic very often. The primary care folks around here are very good at getting those kids in when they need to be seen. The two times in my career, when I've seen kids where I was worried that weren't caught initially, were when there's just some relatively minor balance problems, but on exam were pretty significant balance problems. Like they couldn't do a Romberg and had trouble with finger nose finger, couldn't do tandem gait very well. They could kind of fake it, but it was not normal. And those two kids actually, both of them ended up having hydrocephalus that was then treated by from a tectal plate glioma that was treated by neurosurgery. And one kid, another one I forgot, did have a cerebellar tumor that was removed. That's pretty uncommon. But some of those subtle signs, if there's a headache, new headaches, and even subtle signs, I would just have a low threshold for imaging. The two O's are sudden onset thunderclap headache, where there's a concern for a bleed or possibly a stroke. Usually we're worried about a bleed or aneurysm rupture. The second O for Snoopy is debatable. It was occipital, and there's in the last couple of years, the folks from Cincinnati published a series of their data looking at kids with occipital headaches and really found that that was not a major risk factor for having a dangerous or intracranial lesion. That being said, if you have a young kid with a new occipital headache, maybe it's because I was trained before those papers came out, but I still have a pretty low threshold for imaging those kids. Obviously, pattern change, which we talked about, new symptoms from a previously stable pattern. This is a little stretch for the last P, but precipitants. So if they have worsening headaches when they're pooping, peeing, um, bending over, standing up, if their headaches get a lot worse when they stand up. I'm not just like, oh, I feel better when I lay down, but if their headaches are a lot worse when they stand up and they've had maybe fell off a horse or had some trauma, you worry about a low pressure headache. Obviously, if their headaches are always worse when they lay down, pretty quickly after they lay down, then we worry about elevated pressures for all different reasons. So things that are unusual things that are triggering their headaches. And then a young age. So kids who are less than 6, who we unless they have a pretty typical pattern, may need more workup. So again, these are the yeah, red flags and yellow flags. So red flags, ED would be worst headache ever with peak intensity, severe intensity within 60 seconds or less. They need to maybe even call 911, and certainly call 911 if they have altered mental status. Worst headache ever. But again, that's a little harder because everybody has a bad headache at some point. But if they have new onset vomiting when they're awake, or headaches that are really waking them up in the middle of the night repeatedly, um, and they've got vomiting, those would be ER. If they have an abnormal neuro exam, again, ED. If there's other concerns about systemic disorders or acute systemic illness that could be dangerous, fever, and concern for meningitis, obviously those kids would go to the ED. Yellow flags, maybe consider referral or urgent referral, which we do have, as I hope many of you know, we have what we call our AAA clinic, which is for acute patients, so that you can contact the neurology providers. And we have some clinic spaces every day, almost every day, to see kids who need to be seen urgently, but maybe not in the ED. So you can uh, contact us to be seen. Have a kid seen in that clinic if it's appropriate. Um, Also consider the new daily persistent headaches, where they didn't have any headaches, now they got a headache every day. Headaches are consistently waking them up. Not that they wake up and have a headache, but that the headache wakes them up consistently. Everybody with migraine is going to have some headache occasionally where it wakes them up. But if it's happening consistently and not just once in a blue moon, we need to really make sure we've done our due diligence and worked up that kid. And again, the position or Valsalva induced headaches. So this is from the ICD-3, so International Classification for Headache Disorders 3. So that for migraines, I always tell my patients this. I wish we had a scan or the Star Trek scanner or a swab, that would tell us barcode that would tell us who has a migraine, who has a tension type headache, and what treatment they would need. We're far, far from that at this point. So to get a true migraine diagnosis, you really need multiple attacks, so more than 5, that last from 2 to 72 hours for kids, a little longer for adults. In kids, the headaches are often bifrontal or bilateral temporal. Headaches in adults being unilateral is one of the criteria. Pulsating pain or throbbing pain. In kids, if you have time, if you can get them to draw you a picture, that's great. Sometimes when we don't have time to draw a picture, I'll ask them, if you did draw a picture, what would it look like? And have them try and tell me what it would look like. The pain is moderate to severe, gets worse by doing activities. I will ask to get these checked off for some of the kids who may not be checking all of the boxes, or a little not sure about some of the problems with light, problems with sound, nausea. I'll ask them, if you went running up a flight of stairs or slow jog around the block, would it make your headaches worse? And someone look at me like, I have never ever done that when I've had a bad headache. That's crazy. And their parents look at me and say, well, yeah, they can't really get out of bed and they would feel pretty terrible if they walked around the block. So that can be helpful. So the nausea and vomiting, or phonophobia. And for kids, officially, you can say they put their head, go in a dark room and it needs to be quiet. They yell at their brother or their sister when they put the TV on. That can be inferred as problems with sound. And then the lovely last line that's in all of the ICD-10 criteria, not attributable to another disorder. So you still need to do your due diligence until we can find that migraine scanner or migraine swab. So what about aura? So aura is estimated around 20% of people with aura. This is the video that's playing here is sort of a dramatization of what an aura looks like for one person. This can last 5 minutes and up to 60 minutes. Rarely, if it's lasting longer than that, again, they should probably see someone else. Um, it can occur before a headache, but can also occur on its own without a headache. The visual aura, like I said earlier, is most common. The second most common aura is going to be numbness, usually unilateral, but interestingly, it can go from, it's one of the few causes of neurological cause of numbness that can go from the left side to the other side, or right side to left, or left to right. Um, and I always, when people tell me they've been weak during a migraine, kids who have tingling in their migraine really will often describe it as feeling weak because it feels different and feels weird. But it's, if we did an exam, it really wouldn't be truly weak. They would move, could be moving it differently. Obviously, if they have any stroke-like symptoms, you need to call 911. If their face is droopy or they can't move their arm, they should be seen emergently. Speech and language is a little bit more common than true hemiplegia or confusion or some dizziness with having a vestibular migraine aura. But the most common one is the visual aura. It's not always doesn't always look like the rainbow stripes. Sometimes it can be zigzags or squiggles that are clear. Sometimes it can be dots that float around. Sometimes it can be um, sort of a circle that gets bigger and bigger. Occasionally, people have black dots. That's a little less common. But the generalized blurry vision was very common in migraine and doesn't always mean it's an aura. And that's going to be more important when we talk at the end about migraine and contraception, because there's the big issue there is for girls or women with migraine with aura and worrying about the risk of stroke using combined oral contraceptives. So if it's just blurry vision and they kind of say this, it's just, I just can't see as well, things get just out of focus, that is not typically a typical aura. Imaging. This, where there's lots of guidelines, but when you're with a patient and a family in a room, sometimes those guidelines are a little hard to discuss. So there's folks who will say, yes, we should do the MRI. And there's a brain tumor, it's the most common malignancy in childhood. It's not common, but it's not super, super, super rare. Um, and some of them will only have headache as this is their main symptom, can provide peace of mind. However, even with an abnormal neuro exam, only 2% had a brain lesion that required intervention. So it's a very, very, very uncommon cause for headaches. Most people will say, and the guidelines are on the next slide, most people will say that we should not be doing imaging for kids with recurrent headaches who have a normal neuro exam. CT has exposure to radiation. And again, agree that if we've got a non-urgent case, we're not worried about a bleed, I'd prefer to do an MRI if possible. Here at Seattle Children's, you can see this next bullet point. Yes, they're expensive. However, we don't do gadolinium for kids unless there's some other reason why we're doing an MRI where we suspect infection or other inflammation or demyelinating disorder. And here at Seattle Children's, our radiologists are able to protocol it. And if they see something unusual, they will review the scans before the kiddo leaves. And if there's something that's abnormal or unusual, they will most often be able to add gadolinium on the spot. So I do not order these with gadolinium for our children. The other reason not to avoid them is because there's sedation can be involved. There's a lot of incidental findings, and that can cause more angst and more worry and sometimes distrust that complicate management at times. So that the risk of pathological finding are very, very low. Imaging will change management in only about 2% of the time. So for the American Headache Society, again, AAN and AAP, there's no necessity to do neuroimaging in patients with headaches consistent with migraine or tension type headaches with a normal neuro exam and no atypical features or red flags. Then the choosing wisely is through a different group that is providing guidelines. And again, they recommend using an MRI over CT if possible. but not performing neuroimaging for patients with stable headaches that meet criteria for migraine. And I cannot see the chat, but hopefully folks are putting in their questions so that we can go over these at the end. I just wanted to make sure we got through as much as we could through the main arc of the slides. But please put in your questions in the chat. Patricia's going to be collecting them and we'll talk about them at the end. All right. So now,
And just really quickly,
mhm,
I
yep,
misspoke at the end. If you do want to ask a question live, please raise your hand and we will unmute you. So sorry about that.
that's
I'll
okay.
make that clear.
Thanks. Yep. All right. So we've established there's migraines. What do we do about them? How do we help kids who have migraines get back to their normal lives and have less disability? So this is hopefully, I hope all of you have seen this before. This is the SMART headache guidelines for headache management. This this was developed actually by Dr. Majid Almateen, so you may know, retired recently after a career in pediatric neurology and neuromuscular practice down in Mary Bridge. He told me this mnemonic when we were sitting at a table at the CNS meeting years and years and years ago. I loved it and spread it to everybody. I was actually not directly involved in making these slides, and here it is. And there's also another handout through the American Migraine Foundation, American Headache Society that's for patients, that's got cute pictures on it that goes into this with more detail as well. So it's nice to see that Dr. Majid Amateen's great idea has spread nationwide these days. In any case, so SMART stands for sleep, making sure kids are getting enough sleep. Because if they're not sleeping well, if they're only sleeping 5, 6 hours a night, napping during the day, not getting good sleep, snoring, sleep apnea, that's going to make headaches worse or even trigger headaches. I also you ask what time they go to bed, but also what time they go to sleep. You guys know all the issues. Get those phones out of their rooms, or at least make them promise to put them under the Kleenex box or silent and no vibrations. We know that all that, they say it's silent, but it still vibrates. That still disturbs sleep. We all know that. It's not a good plan. Uh, and that's one of the more common things. And interestingly, I don't you guys would, as primary care providers, know this better than I do, but I've seen that sometimes there's families who kind of think that 8 hours is what everybody should get. So even, 6, 7 year olds, that's sort of the goal, which obviously is not adequate for younger kids and even for our teenagers. M stands for meals and hydration, making sure they're eating healthy meals through the day, so getting their body fuel to make it through the day and prevent headaches. Hydration, that can be the first step. One way to think about it is doing about an ounce per kilogram. And for your older kids or teenagers, somewhere between 64 and 80 ounces per day. There is a post on the Women in Neurology Facebook page that one person found their teenage girls' headaches were getting a lot better now that the Stanley Cup phase and craze is in place because they all have Stanley Cups as a, I don't know if it's a fashion statement or status symbol, but they're drinking more and their headaches are getting better. A stands for activity, making sure it's adequate and reasonable activity, not too much, not too little. Aim for at least 30 minutes of physical activity, getting them outside. For our kids who are doing online school, ask them if they're leaving the house because they may not be. Uh, you guys know that as well as anyone else as well. R stands for relaxation. I kind of also stick stress management in there, making sure that mental health is being addressed because if kids are anxious, depressed, they're that's going to feed into their pain and their pain is going to feed into their mental health issues. And you really need to address all of those things, which is easy. I know easier said than done. Hopefully we're getting better treatment and more providers out there as soon as possible. But other ways of addressing that can be our biofeedback programs, which we have a great program here through the Adolescent Medicine Clinic. There's mindfulness apps. Our pain program has an app as well that you can access on the website, on their website through Tanya Palermo, called WebMap, that Dr. Law and Dr. Palermo have developed to help kids manage chronic pain. Yoga, deep breathing techniques, all those other things to basically turn down the fight or flight mechanism and fight or flight reactions that all of our kids are and all of us are living with all the time, too often. Then T stands for triggers. So modify triggers. Um, if you've I've not ever found that somebody had hard cheeses trigger their headaches in my pediatric practice, but if you've got a kid where hot dogs do it, obviously just stop hot dogs. Um, it's usually not that simple, but trying to keep a diary, modify behavior as possible. Caffeine can be used as a acute treatment, but really only if you're using it 2 or 3 days a week or less. I don't think Red Bull is a great idea in any forms for migraine management or not. But the best headache, we do have headache diaries on Child and then Seattle Children's website, and they're on the American Headache Society website and American Migraine Foundation. But one of the best migraine calendars I ever saw was when a family printed out the entire year and just circled the days in different colors for bad migraine day and mild migraine day, and put in smaller print when they changed medicines or treatments. And then you could just see the entire thing, the entire year, all on one page. And I think it was easier for them to do as well. However, there are apps, Headache Buddy, uh, Migraine Tracker. There's many different ones that one can use if your kids are into that. And a lot of them like doing things on their phone these days. So that may get more traction than the 2024 calendar printed and stuck on the wall. So other things we can do for migraine, biofeedback, like we talked about, that's where you get training. I tell families is where you get training in sort of learning to teach your body how to do things that you don't think you control. Heart rate, your hand temperature, muscle tension, and the biofeedback part is that they'll put monitors on your hands and muscles so that you can see it on the computer and even navigate little characters through scenarios using by controlling and getting better control of some of those autonomic nervous system functions like heart rate variability and hand temperature and sweatiness. As you know, we've got a great program here at Seattle Children with Cora Bruner and her group. Kind of behavioral therapy is very important and is one of the best treatments there is that we know about for chronic migraine, better than medications alone, certainly. I know trying to find it is one of the challenges. Again, that's what the WebMap program through our pain clinic or on our pain clinic, you can download the app anywhere. It's a WebMap app that is trying to make that more accessible to people and kids through computers or online resources rather than having an in-person needing to have an in-person interaction for CBT. There's plus and minus to that, but I wish we could have CBT for everyone with a live person, but we are not there yet. Relaxation training can also be helpful as well. And all of these therapies are usually combined with everything. I usually see it as this usually chronic or disabling headaches are being caused by lots of things. And then the treatment pathway is also going to involve lots of different modalities as well. So here's some other resources. This is through this is the Headache Relief Guide, which takes families or kids through learning about headaches, learning about how to monitor their response to pain, also learning about options to control their headaches. That's really it's you can't print it out. You really need to kind of go through the app for that one. The American Migraine Foundation has also got a lot of resources. And the one that's not on here that I do like a lot is called the Miles for Migraine, which has really blossomed during the pandemic when a lot of the stuff they've been doing locally in a couple small in San Francisco and Philadelphia blossomed to be on Zoom. And so then they really opened it up to everybody. So they've got yoga, cooking classes, um, camp stuff, support groups for parents, support groups for kids. So that's a really nice resource as well. That they whatever for whatever reason didn't include on this slide. All right, so acute treatment. What do we do? So everything's fine, and then you wake up and you have a bad headache, or like my kids, you go to a baseball game, birthday party, and when it's 80 degrees outside and you're suddenly feeling terrible and bummed. So the treatment is really going to depend on the type of headache. For a low level, milder headache, is sort of the level one fire. You can use ibuprofen, naproxen, acetaminophen. I say step back from sort of your really active activities. Ideally, go somewhere a little bit cooler where you can rest, maybe somewhere a little bit darker. You go to the nurse's office for a few minutes. It's a more moderate headache. As soon as you know, if you've got kids with episodic migraine, as soon as you know it's going to be a migraine, that's when you want to really treat it with a triptan plus an NSAID. And then for those more severe ones that are not responsive to to triptans, you want to consider using prochlorperazine or other dopamine agonists with those to try and get better control at home. So this is a list of some of the and ibuprofen and their doses is going to be available. However, I like this slide better. This is a list of the triptans and what's FDA approved and what isn't FDA approved. If possible, I recommend that in primary care, folks are comfortable with at least one or a couple, two, three different triptans if possible. They're generally very safe for our population. Rizatriptan was actually approved for kids 6 and up, and it comes in a melting tablet. So you can use it for even the younger kids. However, I find that it's uncommon that the younger kids need the rizatriptan if they're taking a reasonable dose of ibuprofen, and you can add acetaminophen to that and caffeine. But there are a few patients in our panels who are younger and still benefit from the rizatriptan. Comes in two sizes, either 5 milligrams or 10 milligrams. Almatriptan is another one I've been using more recently. It is one of the more effective medications, and yet or at least as effective as the sumatriptan and rizatriptan, elatriptan, but has fewer side effects, so the risk of side effects is lower. So that's another one I've used more often recently. The sumatriptan, naproxen, Trexamet is also approved for those over than 12s and older tablet. Sorry, it's a tablet. I don't use it a lot because it's often not approved by insurance. So I don't have a ton of experience using the tablet that's combined, though I always recommend that the kids start taking a triptan with some sort of NSAID. Zomegs also is the only nasal spray that's approved for pediatric patients. However, this is where the story about sumatriptan comes in. As you may know, sumatriptan was the first triptan that was approved, and they did the pediatric studies just the same as they did the adult studies, not taking into account the fact that kids will have a higher placebo rate than adults. So those studies in pediatrics really didn't show efficacy or difference from placebo. And then by the time they could have gone back and repeated all the studies, it seemed like it was about to go generic. So those studies were not finished. So there are a lot of studies, a significant number of studies done by the pharma industry showing that sumatriptan is safe. It's just that it's not effective. And you probably will notice that insurance companies often won't cover things like almatriptan or naratriptan or zomatriptan or any nasal spray before trying oral sumatriptan first, which I think is just part of the way we do business these days. I'm not worried about it being dangerous, and it is effective for a lot of kids. Please put comments or questions in the chat if you want to talk more about this at the end. So, when you're prescribing triptans, definitely let them know that they can and even should take a second dose if their migraine isn't gone in 2 hours, as long as they've not had problematic side effects. This is one of the slides that I don't quite agree with. This says no more than 2 doses in 24 hours. You don't want to for sumatriptan, since there's or some of the medicines that have multiple doses, you if it's a teenager, you just want to make sure they're not taking more than the maximum dose in 24 hours, which would be 200 milligrams for sumatriptan, 20 milligrams for rizatriptan, those types of things. You want to keep it simple, it's fine to say no more than 2 doses in 24 hours. And the goal is to take it really 8 days a month or less, or 2 days, 2 to 3 days a week or less. Uh, the to avoid medication overuse headaches or rebound headaches. In truth, if you took it for 3 days 1 week, or even 4 days for a bad migraine 1 week, and then didn't take it the rest of the month, that's fine with me. Um, People do still ask about using triptans because with SSRIs, because they're a serotonin agonist, or SNRIs, but there's not data to support that concern. And most of the patients I see are not on high dose SSRIs or SNRIs usually. And the triptans are really something you should be using very short term. They are in and out of your system relatively quickly, and that unless kids are on would be a really unusual situation on lots and lots of serotonergic medications, that's reasonable to use the triptans. I do try and let them know that there are potential side effects. Most people don't have these, and they're not dangerous, but they feel weird. And if you haven't talked about them, kids and parents can get kind of freaked out. Their jaw or neck or some of the chest can feel tight or uncomfortable. That is short lived, but and does go away and isn't dangerous. Some people just feel weird and like tingly. Somebody told me their scalp felt like tinfoil, but it's again goes away and isn't dangerous. But these side effects can be uncomfortable and make kids not want to take the triptans, even if they help the headaches. So that can be an issue. So that's when I may try naratriptan or amitriptan if kids are having side effects. When would you not want to use triptans? So if anybody has cardiac disease, has had a heart attack, coronary artery disease, ischemic heart disease, they've had a stroke. Kate LaFond does not like her patients to have triptans. We're trying some unique and outside the box therapies for some of her kids. The rare migraine subtypes like hemiplegic migraine, also there's debate about this, but as a primary care provider, you should not be giving those kids triptans. Those kids with hemiplegic migraine, please send them to us. Like we're happy to see them. And there are genetic testing now that may help to inform therapy. So we're happy to definitely would be happy to see kids with hemiplegic migraine. Definitely, I would recommend sending to your local neurologist because there can be complications with those kids. Other contraindications would be if they have uncontrolled hypertension, severe hepatic problems, or kidney problems. And then I also don't want to use triptans in kids with transplants because there have been some case reports of transplant rejection associated with triptan use. And if I've got kids with rheumatological disease, I will want to talk to their rheumatologist before considering triptans in case there may be vascular involvement. Sorry, there we go. And I did happen to see, one of the chat question about caffeine. So as you may know, in our ER, we're using caffeine now, or have the option for using caffeine. I, don't have the dose of caffeine off the top of my head for younger kids, but for teenagers, it'd be about 100 milligrams. That's what we typically use. And there are tablets that you can use rather than having them use coffee or sodas. Because you can get into that trap of having your kid, somebody who says, "Oh, I have a headache," because every time they get a headache, then they would ask to get their sodas, which is not ideal. So this is a pediatric migraine action plan that we have a similar one for kids at school. So teachers know about the plan. It's what to do at baseline. Yellow zone is the medicines to take, when to take them, how to take them. And the red zone is when to call your neurologist. So if there's a lot of nausea and vomiting, you want to combine this with an anti-nausea medicine. Again, if NSAID's not effective, try a triptan. Make sure the dosing is correct. If the triptan's not working, you can add a dopamine agonist. or consider switching triptan site types, uh, or switching to a triptan with a longer half-life if the headache comes back. Again, but if there's kids that are not doing well on one or two triptans and haven't done well on a preventative, certainly feel free to send them to us. So when should we think about migraine prevention? So usually we think about this if kids are having somewhere at least 4 or around 4 disabling migraines per month. However, if they're less frequent and they're interfering with school or other activities, or if they want to start think about prevention for other reasons, or if their acute and painkiller medicines aren't working as well anymore or having side effects, that's when you want to consider prevention. Like I just saw somebody earlier this week where he's only having migraines 2 or 3 days a month, but they were terrible and he was in bed. He wanted to go back on a prevention. So these are some of the supplements that we use. These are the, even though I did not write these slides, these are the ones that I use most frequently as well. B2, magnesium, CoQ10, and melatonin. I will consider if there's problems with sleep. The evidence about it helping with headaches is less convincing, but if you've got a kid who's not sleeping, melatonin can help with sleep. That can help with their migraines. The downsides of B2 is that it makes your pee bright yellow and fluorescent. Magnesium, you want to make sure you're using a form and a dose that's not causing diarrhea. So the chelated forms tend to be better tolerated. CoQ10, again, is pretty safe, but it's just a little bit more expensive. We don't recommend using butterbur because if it's not processed correctly, there can be chemicals in it that are hepatotoxic. And here in the land of unregulated supplements, even when they say they're free of these things, that they're still found. So for pharmaceuticals, the most common ones we use are topiramate and amitriptyline. These have the better data. Propranolol or beta blockers, Depakote. And I use a lot of cyproheptadine because it is so safe. Topiramate, these are the doses that it can work up to. You don't want to start at those doses, obviously. With topiramate, we worry about side effects like mood changes or problems with word finding. And if kids find that it's helpful for their headaches but are having some side effects, I'll try using it just at night rather than twice a day. Amitriptyline, again, there's a black box warning for suicidality. And if it's a kid who is depressed, yes, this is an antidepressant, but I tend to avoid it if I really am worried about depression because amitriptyline and the tricyclics can be lethal in overdose. So we want to avoid those. But make sure that we're not dealing with that, or at least talk to the parents and family about, is this a safe medication to have at home? Propranolol or other beta blockers can be helpful. They put TID here. I don't know anybody that can do TID dosing, so I usually do it BID. Or we start working up somewhere between 1 and 2 per kilo. But again, avoiding if kids are really apathetic or having problems getting motivated or depressed. And obviously without asthma. Don't use it if they have asthma. Depakote, I don't get to use very much because I try and avoid it in our teenage girls because the risk of birth defects, about 4%, will have birth defects if you're on it throughout pregnancy. But it can be very helpful for some kids. And I also just use this once a day, use the long-acting form at night, working up to about 1,000 milligrams for our teenagers. But I use cyproheptadine a lot. It comes as a tablet and a liquid. I'll use it for our younger kids who are having more frequent migraines, particularly if they're having trouble sleeping. And it can also increase appetite for some kids, for better or for worse. So that's just something to warn them about. I had to take a kid off because he came back in a couple months and his mom was like, he doesn't fit any of his clothes anymore. He's eating 4 sandwiches at night. And at lunch, I said, all right, never mind. We need to find something else. So that's one of the downsides. So as you may have heard about the CHAMP study, this is the NIH-funded trial of topiramate, amitriptyline, placebo. And the short story is that they all helped about 60% of the kids in terms of migraine prevention. These were kids that had between 4 and 28 days of migraine per month. But I still think that there are some kids where both of these medications may be helpful. But basically, I think this study just reinforces the need that it needs to be a multidisciplinary approach using lifestyle changes, perhaps feedback, incorporating mental health, diet, exercise, all of those things in addition to medications. So you just, and also if you're going to use a preventative treatment, whether it's migraine relief, like a magnesium or a supplement or a pharmaceutical, it really, when you look at studies of kids who do better on it, it takes a while. It's not overnight. They need to be on that gold dose for 8 weeks if it's tolerated. Go up slowly. They're having, particularly if there's side effects. If you have a kid who reacts to everything, I go up super slowly. And it might be that I would, use amitriptyline for a kiddo who may have some neuropathic pain, who isn't depressed, who is having trouble sleeping. I might use cipraheptadine for a kiddo with allergies who's got nausea and is very slender and maybe could use some extra. A higher BMI would not necessarily be a bad thing. And that it's not forever. So once things are going well, you can talk about trying to come off of it. So the other thing, so when to refer to a headache specialist, we can offer research studies. There's the newer medications that are being used to target the CGRP system, both the injections that are once a month injections like galcanezumab or erinumab for migraine prevention, or the pills, the tablets that are used for both migraine prevention and acute treatment, rimegepant, ubrogepant, and atogepant. We are starting to use those in some of our older teens with refractory migraine. We're doing Botox now for several years. We've just started being able to do Botox. There's these new neuromodulation devices. I'd encourage you, you could do a whole talk on these. The remote electrical neurostimulation is this device that goes on the arm. And I'm hopeful that will even become more common in general primary care practices because it's pretty easy to use. It's not super horrible expensive. It's like $49 for the first one or $200 for a pack of 3. And there's 18 uses in each one, used for migraine prevention and acute treatment. And it's pretty easy. So I know that the company is also going to be going to some general pediatrics and general internal medicine conferences. So I know I'm out of time. We got 2 minutes left. So this is just briefly talking about avoiding combined hormonal contraceptives and for women who are females with migraine with aura. However, the International Headache Society says low dose estrogen can be prescribed in migraine with simple visual aura. So our goals are to limit stroke risk. There are older studies, again, with higher doses of oral contraceptive hormones, show that there was a significantly higher risk of stroke for women with migraine with aura when they were on combined hormonal contraceptives. It was a higher risk with higher dose, also higher risk with higher frequency of aura. So if you can, for contraception for that population, try other things like progesterone only contraception, an IUD, implants, non-hormonal IUD, other things. Migraine without, or they're talking about really menstrual migraine. You want to try and keep estrogen levels stable, so you could use a low dose estrogen there to try and limit the fluctuations. But if something changes about the migraine, as soon as you start a hormonal therapy, it should stop. If they start having an aura with hormonal therapy, they recommend stopping. So the problem with low dose oral contraceptives from my adolescent medicine colleagues is that that tends to lead to spotting to our teenage girls, and they do not like that. So it's not so easy. However, when I do have patients, especially who are transitioning or working with gender clinic, where we talk about the risk and they are saying, look, don't have any other risk for stroke or thrombosis, and I need to be on estrogen and progesterone for other reasons, we have those discussions. So that comes to the end of the AHS portion. Basically, make sure we're managing migraine, making sure we're not missing anything dangerous, providing acute treatment that works, and following up to make sure that treatment is working is important. Setting goals for school and plans for how to manage things at school with clear instructions for the nurse and the teachers. There's also a whole website and a whole program called Migraine at School that's got a lot of really good information and guidance for teachers and school nurses. And then use a multimodal approach to manage migraines and to prevent and limit disability. So this is also some of the options with the American Headache Society, American Migraine Foundation. They have a lot of resources. And I'll just go through these slides real quick. These are just the things we're offering at Children's. We now have uh, two nurse practitioners who are doing only headache. Dr. Hazar Chatterjee joined me in the headache program as well. Our general neurology providers all see many headache patients. We have a great team of nurses and administrators who really make the program run. Um, we have a still, unfortunately, Dr. Law went to a great job in Kansas City. So we're still, Dr. Walco is seeing patients with me for our multidisciplinary program through as a pain psychologist. It's still only internal referral. So if kids are having a lot of disability and are not responding, then our providers will refer to that program. We're doing Botox. We're continuing to work with the ED to make sure we're continuing to improve and change that and making sure it's effective as possible. We've just started being able to offer nerve blocks for acute headache control. We have an infusion center for acute migraine treatment for the Seattle Children's neurology patients who are straightforward. We've got intracranial hypertension multidisciplinary clinic for those kids with more severe and complicated IIH. We're doing clinical trials. We've also got guidelines and algorithms that Patricia and I can guide you to, and that'll be in the slides. Some options for treatment as they're getting referred or as you're waiting for them to be seen at Children's, as well as the headache tools kits, which I hopefully many of you are aware of, links to resources for patients and families. And then again, the WebMap mobile resource for kids with teenagers, targeted for teenagers with chronic pain. So here is the evaluation. This hour went really quick. Hopefully you got, thank you for meeting with us and taking up coming in on your Thursday evenings. And now we can open it to questions. And I can
Yeah, so I will just start reading from the top. And again, please raise your hand if you have a question you want to ask verbally. But the question was, can you please comment about the role of magnesium IV or by mouth for acute and preventative treatment of migraines, respectively?
Yeah, and what I think what I'm going to say a lot is that I would love to have more data. So there is data that acute migraine treatment with magnesium, and we use it in the ER as part of our migraine, can be part of our migraine cocktail, can be helpful for acute treatment. I have put the QR code back up. Sorry, there we go. Um, so that is one of the things that is part of our cocktail. And I wish I had that swab to tell me who was going to respond to migraine, to magnesium, who needs Depakote in the ED, who we should give the dexamethasone to, who doesn't need it. So uh, I don't have the reference on the tip of my tongue. The magnesium, there's several studies indicating that magnesium can be helpful even in pediatric studies, and that dose is in the slides of about 9 mg per kilo per day of elemental magnesium for use for prevention. Why exactly it works is not completely clear, but it is one of the things that have been used for a long time. Perhaps it helps again with like the seizures. The NMDA receptors need magnesium to be able to function normally. But with these kids, it's not that their magnesium levels are low. There are some folks that will check red cell intracellular magnesium levels, but it's hard and expensive, and I just don't typically do that.
Okay, so the next one is caffeine-induced meds for kids. How much is safe and how often per day for best relief, but not taking in too much?
Yeah. So I again not much data. So I will use, and you can think about using maybe 50 milligrams in smaller kids and 100 milligrams in teenagers. We generally want to do that 8 days a month or less uh, to avoid medication overuse headaches. We know, I mean, probably lots of people on this Zoom call or whatever this is have had the experience of caffeine withdrawal causing headaches. So that's one piece. So if you're having caffeine all the time, then you can actually make headaches worse because you forget your caffeine. In addition, there is reasonable data that caffeine use can lead to medication overuse type headaches. However, there's just something that was published. You may have seen it last. I saw it while I was on the plane last week. Looking where they just did a cross sectional study looking at caffeine intake and migraine and didn't find differences in migraine frequency between those who had a lot of caffeine and no caffeine. But it wasn't a longitudinal study, but it raised some interesting questions like, so is this dogma that we've been talking about caffeine being a double-edged sword and maybe not the best thing for migraine? Is that really true or not? So there's a lot we need to. It would be lovely to have better data.
All right, next question is, what are your thoughts on ciproheptadine and Migraleaf? I'm not sure if I said that right. For preventative therapy for migraines, and when would you start these?
Yeah, we use those all the time. So those would be again with kids who are having at least certainly for kids who are having 4 disabling migraines per month and maybe even before that. I think which if would I pick ciprofloxacin over Migraleaf or vice versa? I don't know. It really depends on the kid and the family and what's happening. Migraleaf does have a which is you put it up here. Migraleaf is a combination of B2, magnesium, and a feverfew. Um, and they do have a junior form, which is nice. It's easier to swallow, but it's still a pill. So that can be very helpful. It's not cheap. Like if you need less expensive options, you could just go with a magnesium only. Um, and there's another one of our Catherine's found a powdered form that's called Cove Beam. That's a powdered form made for adults, but also has CoQ10, magnesium, and B2 in it. So that's another way that you can try it for younger kids. So I recommend using sort of a quarter or a half because it's an adult packet. Again, we kind of in some ways make do with a lot. There are powdered forms of magnesium. I'm sure as you know, most of those are mag citrate, which can be a little more diarrheogenic. And then ciprofloxacin, I use again as I use that pretty regularly, especially for the younger kids. But I probably do things differently in that I also use it for older kids. The dogma is that you have to use such high doses in older kids that it doesn't work. But if I've got a kid who's got a lot of allergies or has a lot of potential comorbidities or reasons I don't want to use some of the other medications like topiramate or beta blockers or something else, I will use ciprofloxacin as a trial because it's very safe.
Right. So if that question did not get answered because of the technical difficulty, please feel free to either send it again or when we get the email we send out again, you can ask and I will make sure to follow up.
Yeah, and you can send me an email too if
Okay,
people
yeah,
want. It's
yeah.
just my
I will
first
make
name,
sure you
not my last name.
for information. The next question is for non-steroidal anti-inflammatory drugs plus triptan. Is that still the best treatment to abort migraines that have been going on for greater than 24 hours in an outpatient setting?
Yeah, I would still use that is a good question. And I don't know, did you see our paper that we worked on with Emily Hartford and Jessica and I looked at our use of triptans in the ER because we're one of the few ERs in the country that does that. To our knowledge, there's a few, but not very many, because most, and I get looked at askance when I say that at some of our headache meetings, national headache meetings, because that it's true. These triptans and treatments work best if you take them at the onset of a migraine. I always tell people like if you can squish it when it's a little mini migraine monster rather than a big huge monster, much easier to do that when it's still a little mini migraine monster. However, we do have success using the triptans in the ED. I just saw it happen the other day. Um, so it's still worth trying, in my opinion, even if the headache's been going on for more than 24 hours.
Okay, and then this is, I'm not sure this is actually a question or more of just a thought, but long-term prognosis, mild forms often become remitted or resolved if they don't morph into other migraine forms. I don't know if you want to make a comment on that or.
Yep. So, so I guess a long-term prognosis, I would love to see the study where, and maybe if I've missed this and somebody else knows about it, you can let me know. Um, where we can show that if we can prevent migraines, make migraines less frequent, then they're more likely to have episodic migraine rather than chronic migraine as they get older or have them go away. Um, and it's certainly mild forms come and go. Um, and it's hard to predict who's going to do that. I would say it's more likely for I always tell families it's more likely for boys to outgrow their migraines. There's times when I'm just really hoping to get them down to that point where their height stable, they're done with their growth spurt and things are settling down and their migraines get better, but not always. For girls, it's much less. I would say there's more of a chance that they can get worse as they get a little bit older, but they often do settle down once they kind of get through eighth, ninth grade. Often, and I've seen that migraines often get better for a lot of kids once they get out of high school and can make their own schedules. Some of that both academic, cognitive, and social stressors are a little bit better. Um, so that's true. So yeah, there's there's data. So you can go into chronic migraine, you can come out of chronic migraine. The new daily persistent headache group is a little different, but still better prognosis than it is for adults. If I addressed this question.
So that looks like the end of the chats. It's about 7:15. So thank you very much, Dr. Bloom, and thank you everybody for joining. Our team will be following up again with, like I mentioned, with another email to have the evaluation information, and then another email after that with the recording and the slides and some other information that Dr. Bloom had mentioned throughout the presentation. So thank you very much.
And thanks. If anybody has any other questions, feel free to shoot me an email. It's just heidi.bloom@seattlechildrens.org. And thanks for sharing your evening with me, with us, Patty and
Yes.
everybody.
Yeah. Thank you, everybody.